DBT was created to solve the problem of people feeling like their lives weren't worth living.
At its core, it's a therapy designed to help people manage their emotions. So learn how to understand, regulate, cope with, and work with their emotions when they're having troubles with them.
About 42% of high schoolers say they constantly feel sad or hopeless. That's up more than 50% from 1999. 41% of undergrads reported overall depression, and 14% reported suicidal ideation in the past year.
One of the major misunderstandings that I see is related to the skill of radical acceptance. I've been so healthy, I eat well, and I exercise, and I take good care of myself, and God damn it, how did I get diagnosed with cancer? I really want to say that this was probably the hardest interview that I've had.
I'm Tim Green, and I have ALS. But this podcast isn't about ALS. I don't want you to feel sorry for me. I'm a father of 5, married for over 35 years, a New York Times best-selling author, an NFL first-round pick, and a practicing attorney. This is Nothing Left Unsaid, where my son Troy and I sit down with extraordinary people for raw, honest conversations about life, its toughest trials, and greatest triumphs. My voice in today's episode is powered by 11 Labs. Today's guest sits with people in their hardest moments and teaches them how to stay. Dr. Shireen is a leader in dialectical behavior therapy, a framework built to help people regulate overwhelming emotions and build lives worth living. Her work bridges science and compassion, structure and mercy, and recently came together in her book, Real Skills for Real Life. We're going to talk about suffering and hope, faith, family, and what it really takes to change when life feels unbearable. Shireen, welcome to the show.
Thank you so much for having me. I'm delighted to be here.
For listeners meeting you for the first time, if someone is sitting in their car or office right now feeling overwhelmed, ashamed, or exhausted by their own emotions, what do you want them to understand about who you are and why the work you do exists in the first place?
I really appreciate that question. I think the bottom line of what I want people to know and to take away is that there's always something that you can do, whether it is something that you can do to change or problem solve the situation that is causing you intense suffering, or whether it's shifting your mindset to becoming more accepting or tolerant of what is happening. Either of those presents an opportunity for something new and something different. And as we often say in DBT, but also elsewhere, the only constant is change. So even if you're feeling miserable, intense suffering in this moment, it will not last forever. And something will change. And you have some power within you to make some of that change happen.
What's like the 30-second elevator pitch on like what DBT is? So if someone's hearing it for the first time, it's like they kind of get on the same page before we dig into it.
Sure. I might have a hard time with 30 seconds, but DBT stands for a therapy called dialectical behavior therapy, and it's a form of talk therapy that's rooted in cognitive behavioral therapy, which is basically an evidence-based approach to helping people with their mental health problems. But DBT was developed with a couple of different additive components to CBT. So one is that it was developed for folks that really have significant complex mental health problems. And so it was originally designed for a population that most people didn't want to treat, called borderline personality disorder, which is associated with a lot of emotion dysregulation and suffering. The other component that DBT adds to standard cognitive behavioral therapy is a set of concrete, learnable skills to help people learn how to regulate their emotions, be more effective with other people, be more mindful, and tolerate distress more readily. So the package of skills is another component of DBT that is important for people to learn about.
So is the big change in DBT that it's becoming more mainstream and not just for people with kind of borderline personality disorders?
Yes, exactly. So it was developed initially in the 1980s by a woman named Dr. Marsha Linehan at the University of Washington. She was my mentor in grad school, so I learned it directly from her. And almost immediately after she developed it and put out her book for borderline personality disorder, people started approaching her to say, "Can I adapt this for eating disorders? Can I adapt this for bipolar disorder? Can I adapt this for depression or anxiety?" Because people really resonated with the underlying principles of DBT, which is that most problems that we experience are a result of emotion dysregulation or feeling out of control with our emotions or thoughts. And so people really resonated with that and said, "I want to apply this treatment now for this problem or this population or for everyday life problems." And so I think that is true, that it's been adapted and expanded way beyond its initial population.
Let's break this down a little bit more. When you say there is always something someone can do, define that in plain human terms. Dialectical behavior therapy sounds clinical, almost mechanical. In plain human terms, what problem in people's lives was DBT created to solve?
DBT was created to solve the problem of people feeling like their lives weren't worth living. And the goal of DBT is to develop a life worth living, no matter what your situation is, no matter what your problems are, no matter what your family situation or family of origin was, no matter what medical problems or degree of trauma you experienced. We believe that everybody can develop a life worth living, and that's what we aim to do.
You trained in a lineage that runs directly back to Marsha Linehan. For people that don't know, can you explain who she is and how she impacted the field still to this day, but also what has changed?
I really believe, I mean, obviously, I'm a little biased here because she was my mentor. She has had a profound influence on my life. I would not be doing anything that I'm doing now if it weren't for her. And given all those biases, I will say I think she's also transformed the field of clinical psychology. It would be hard to find a psychologist or even a mental health clinician who's a social worker or a counselor with another degree that hasn't heard of her. So she, as I mentioned, was a university professor at the University of Washington in Seattle, Washington, and she wanted to develop a treatment for people who were chronically suicidal. And for those people who don't know, much later in her career, she came out with her own personal story of having been herself quite suicidal and engaging in significant amount of self-injury and being hospitalized for much of her adolescence. And she was her story was published in the New York Times, and her book, her memoir, was published a few years ago to account for that. She wanted to develop a scientifically based treatment for the problems that she herself experienced. And at the time that she wanted to do this, she had to apply for a grant from the National Institute of Mental Health. That's what you do to get any money to study a new novel psychotherapy. And at the time that she was interested in doing this, NIMH said the only way you can get a grant to study a new treatment is to attach it to a diagnostic disorder. And so she had to look for what diagnostic disorder did she want to attach this treatment to. And really, in terms of the diagnostic manual that we all follow as psychologists, there's only two that talk specifically about having suicidality within its diagnosis. One is depression, and the other is this disorder called borderline personality disorder. And Marsha Linehan said, everybody's studying depression. They don't need another person studying depression. I want to study something that nobody else has studied, and I want to leave a mark on the field. And that's why she chose, by her report, that's why she chose borderline personality disorder. Marsha herself is a really charismatic person. She is an exceptionally good teacher and instructor. Anybody who's interested can go online and find videos of her teaching. And I think that is one of the reasons that this treatment took off, is because you could listen to her talk and immediately want to do whatever she says. She's just that sort of person. And so I think the combination of her personal life history that informed her mission, her dedication to treating people that nobody else wanted to treat, and her dedication to really focusing on decreasing suffering and building a life worth living are part of her profound influences on the field.
DBT is built on a paradox: radical acceptance and committed change. Where has that tension shown up most personally in your own life, not as a clinician, but as a human being?
You know your stuff, Tim. You know your stuff. You're right.
Nice, easy question.
So the question of well, first, just to back up and say, yes, the dialectics in DBT is talking about the fact that tension and polarity is constantly there, and what we are striving to do in those moments of tension and polarity is to work to find a synthesis. And one of the major dialectics in the treatment is this balance between acceptance and change. Accepting things that we cannot change, and changing things that we actually have some influence over. And so your question was, where have I come up with this in my own personal life? I will say every day in some way or another. So two immediate answers come to mind. One is related to parenting and having children, and realizing that children are born into this world with their own biology and their own ways of learning, and their genes and everything that make them different than how you might have expected them to be, or even what you thought it would be like to have a child. And so I'm parenting a 12-year-old and a 14-year-old boy now, and I feel like there's a constant tension between what do I accept about how they are, what they want, what they like, and what do I push to change, right? They don't want to study for a test that they have the next day. Do I work with them to come up with a plan, to insist that they study, to take away everything until they study? Or do I accept that they can make their own choices, right? And how do I balance that? Because I'm also trying to teach them how to be good human beings who can follow through with plans. So that's one way in which I think acceptance and change shows up. I think parenting, for me anyway, is a daily example of that. Another example is my own personal history with cancer, and having had a cancer diagnosis, and feeling in that, especially in those initial days of getting that cancer diagnosis, the thoughts that went through my head about how unfair it was. I've been so healthy. I do all the quote unquote right things. I eat well and I exercise and I take good care of myself. And God damn it, how did I get diagnosed with cancer? And really finding that in those moments, like a real lack of acceptance, those thoughts, actually, this isn't fair, this shouldn't be happening, are emblematic of non-acceptance. So for me, that tension also is I have to accept that, or I had to accept that this was actually happening to me, that this was a diagnosis that I now had and will carry with me for the rest of my life. And accepting that allowed me to, first of all, have a greater sense of serenity over the experience, right? I can't not have cancer just because I don't want it. And it allowed me to be more effective in terms of making the changes that I needed to make. Talking to work about what I needed to do differently, talking to my family about it. So that's another example of the way in which acceptance and change shows up. But really, I almost, those are like two big examples, but I think on a minor level, it happens every day.
How long did it take you to go from learning about DBT to being able to like implement it like that on your daily life?
It's been a process, and I feel I often talk about DBT and DBT skills as like learning a language, and how when you first are trying to learn a new language, you're just trying to remember the words and remember the conjugation of the verbs and it's very arduous to like do the word by word translation to get there. But ultimately, what you're trying to do when you learn a new language is get to the point where you're fluent, right? Where you could respond in a conversation without thinking, oh, let me translate this word by word. So I pretty quickly would say, recognize the value of these principles in DBT and the value of these skills, and recognized that it's important to incorporate in my own life. And it's been now more than a couple of decades where I feel like I've gotten to the point where I can just, eat, breathe, and sleep it. But it takes time. And that's the other thing that I want to tell people when I teach them the skills. It's not like I'm going to teach you, for example, the skill of radical acceptance. How do you fully and totally accept this moment exactly as it is? When I teach you that skill, I don't expect you to master it and know it and never suffer again. I teach it to you to say, like, this is actually a lifelong practice, that every day you might have a situation where you have to think about, how do I fully and totally accept this moment? And the next second, your brain is going to take you somewhere else and you have to come back and radically accept again. So I really think it's a process, and I don't want anybody to feel like they should just get it right away, because I do think that leads to people getting disheartened with treatment pretty quickly, and saying it's not working, when instead, really we say it's working when you're trying it.
Because when the stakes are highest, theory doesn't matter as much. Shireen, you have worked for years with people living on the edge, chronic suicidality, self-harm, and even the belief that life is not worth living. What is the truest sentence you know about hope in that room?
There's not probably one answer to that for me, because there's so much individual difference in how people get to the place that they get where they feel like life is not worth living. The truest piece that I say and that I fully believe in, no matter what, is what I mentioned earlier, which is, I believe change is possible. I believe circumstances can change. I believe that anybody can have a life worth living, no matter what the circumstance is. And if I believe that, that is going to help me be most effective with the person sitting across with me, even if they don't feel the same way. The other piece that I'll just quickly say that's an important part of DBT is, as these questions highlight, we're talking about really hard stuff. People on the brink of despair, people who have attempted suicide multiple times or may attempt suicide in the next day. It is a really challenging group and topic. It's really hard work for the therapist. So one of the required components of DBT is actually something called a consultation team, where every week the therapists get together with each other to provide support and help and guidance. And a therapist could come in and say, I'm starting to feel hopeless myself about this person. I'm starting to feel like maybe they don't have a reason for living, or maybe I can't help them. And the job of the team is to help the therapist get back in the spot of feeling hopeful.
Your book is called Real Skills for Real Life. What was broken or missing in the way emotional skills were being taught that made you say, this has to change?
So the existing skills manual for DBT is a book that Marsha Linehan wrote that is a few hundred pages long, very wordy, and is meant to be used in the context of people attending DBT skills training sessions with a therapist. And balance that with the topic that we discussed earlier, which is that we feel like these skills could be universally helpful across problems and disorders and contexts and populations. My co-author, Jesse Finkelstein, and I saw that there was a real opportunity to help people learn the skills in a user-friendly way outside of the context of traditional DBT therapy. So it's essentially a self-help book, though it could also be used in conjunction with people attending DBT, that uses illustrations, that uses, I hope, friendly, easy to understand language so that it becomes more accessible to anybody who wants to learn more about what these skills have to offer.
DBT skills can look simple on paper and feel impossible in the moment. Which skills are most misunderstood, and what do people usually miss about it?
I totally agree that they look simple and are much harder to practice. And I think that one of the major misunderstandings that I see is related to the skill of radical acceptance, which is the skill to learn, to practice, to accept this moment exactly as it is, whether we like it or not. And I think the general misunderstanding about that when we say to people to practice radical acceptance is they think we're saying you have to learn to like what you're experiencing. And they have a hard time disentangling liking something versus accepting something. So I can accept that I now have cancer and I need to undergo treatment and I need to come to the reality, accept the reality of what that means for me in my life. That doesn't mean I have to like it. It doesn't mean that I have to approve that this is happening to me. It doesn't mean that I have to say this is the best thing that ever happened to me. I just have to accept that this moment is exactly as it is. In the same way that we say that people can learn how to radically accept what they're feeling in this moment, whether it's intense sadness or shame or guilt or panic, you can practice accepting, okay, I feel this in my body. This is exactly what's happening to me right now, without approving of it, without saying I like this, without wanting it to stick around. So that, I think, is the most fundamental misunderstanding about acceptance, is that it's not the same thing as approval or liking something.
Shireen, chain analysis can feel like a worksheet until it becomes a mirror. What is the moment in that process when you often see self-hatred soften into understanding?
In a minute, I'm going to want to ask how he knows everything that he knows about DBT. But in the meantime, so you're asking about chain analysis, and just to provide a little bit of background just to what chain analysis is. Chain analysis is a tool to help understand all the factors that contribute to us engaging in a behavior that we might consider problematic. So in therapy, we would do a chain analysis. If somebody, say, for example, somebody wants to work on decreasing or abstaining from substance use, if they had an episode of substance use in the last week, we would do a chain analysis of that instance of substance use. And we would say, first, tell me everything about that instance of substance use. What did you use? Where were you? How much did you use? Etc. Then we would work kind of backwards and forwards to say, when did the urge to use first show up? What thoughts were you having when the urge to use first showed up? between the urge to use and the actual use, what did you do? And we're filling in kind of all of these, it's called a chain analysis, because what we're saying is we're filling in all these links in the chain. How did you get to using substances? And then also, what were the consequences, right? Short-term and long-term consequences, because these are really important. Short-term is, I felt great immediately. Long-term is, I felt shame and guilt and like I relapsed and a failure, etc. The whole premise of the chain analysis is to understand all the factors that contribute to the behavior occurring so that we can figure out what to do differently the next time. So the next time the urge shows up, instead of doing X, Y, and Z like you did last week, what's something skillful you can do, right? Or if the urge showed up in response to a fight with someone, what can we do the next time you have a fight with someone that doesn't lead to an urge? So it's really about dissecting all of that. But what you're raising is a very common phenomenon, which is that when we ask people to look under the microscope so intently at a behavior that's considered a problem for them, the very act of doing that often elicits a lot of shame, because you're saying, like, here's this thing that you don't want to do anymore, and now I'm asking you to tell me about it in excruciating detail. So that in and of itself is what we would say in psychological language. It's a form of exposure, in the sense that learning to talk about it and all the factors that contribute to it can be in itself very helpful, because most of the time what people do is they want to avoid. I did this terrible thing and I don't ever want to think or talk about it ever again. The problem with avoidance is that it doesn't do anything to help solve the problem. And so the more you avoid thinking or talking about it, the more likely it is that it will occur again. And you get caught up in this vicious cycle. So the chain analysis tool, again, ultimately designed to help people identify different things that they can do to prevent the behavior from occurring. And a secondary outcome is that people become less ashamed, more comfortable talking about it with a trusted person, in this case, a therapist, in a way that becomes more helpful to them.
You have given other people the tools, but I want to know what you do when you are the one who needs them. You spend your life teaching people how to regulate emotions. What emotion do you personally struggle to regulate? And what do you do when you catch yourself slipping?
Every day. I would say for me, the emotion that I have the most difficulty regulating would be irritability, or maybe we could define that as like low grade anger, but irritability feels more accurate to me. And anger or irritability, we say, is often justified in the sense that we say that anger is prompted by our goals being blocked in some way or another. So that happens all the time, actually. Like a car cutting you off in traffic is a cue for anger. Not getting something that you want at work is a cue for anger. Somebody not responding to your email or your voicemail or something can be a cue for anger. Or your kids not listening to you, or your house being messy. Those are all things that could be cues for anger. So one of the things that I want to highlight about why I think your question is so great is that our goal in DBT is not to help people learn to not have emotions. Emotions are actually really important. They're valuable, and they're also part of the human condition. So emotions are going to show up. Instead, what we want people to learn is that, first of all, emotions don't last forever. So often what happens is people feel an emotion and then they think, oh my God, I'm never not going to feel this way again. I'm going to be sad forever. I'm going to be ashamed forever. And we know that emotions will change. So we want people to learn that. But we also want people to learn that they have a whole host of different ways to respond to their emotions. One way is actually to practice skills called distress tolerance, which has to do with like distracting away from your emotions. So when I'm home in the evenings and I'm irritable because my kids aren't listening or they're fighting with each other, I actually often go into my dining room and I work on my jigsaw puzzle that is always just there. And even if it's just for 5 minutes, I go and I work on my jigsaw puzzle for 5 minutes because it distracts me. It gets me out of my stewing over whatever is making me irritable. And it gives me, something else to do. But I also think, there's other strategies you can use, like opposite action, which is an emotion regulation skill, which is to do the opposite of what it is you feel like doing. So when you're irritable, you often want to complain and moan and gripe over things. What's the opposite of that? It's to practice being kind and loving and throw yourself into that and see what that does to your irritability.
Have you noticed any trends in like maybe age? Like if you're working with people trying to use DBT for, I'm making up an age, above the age of 50, they might have the certain triggers, whereas below the age of whatever, 50 or 20 or whatever has similar triggers.
I don't know if like I would say that the triggers change, but I do think there are developmental processes for sure that influence what people want to do with the problems that they have. And I can speak for this for me personally, that I've noticed over time as I've gotten older, I actually am much more likely to lean towards the acceptance side of things. For example, to say, oh, I'm feeling irritable. Okay, right? Or I'm feeling sad about something. Okay. Whereas when I was younger, if I felt irritability or sadness, my goal would be to change it as quickly as I could. So that's what I've noticed as a change, at least in me personally and with some of the people that I treat. But in terms of the triggers, I don't know. Maybe different kinds of interpersonal situations change over the lifetime. So different elements of relationships obviously have influence over how people feel, and younger people have different issues with relationships than older people do. So there could be some interpersonal differences there.
People who are listening to this without the doctoral degrees, how can they start making these changes in their own family, and where should they start?
Yes, I imagine most people who are listening do not have doctoral degrees in psychology and would like to know different ways for learning these skills, applying them in their own life, with their families. So, of course, I would say I hope my book fulfills that function for people, that they can pick up the book and learn more about it. I will also say, though, that our inspiration for writing this book actually stemmed from a project that we did back in 2020 when COVID hit, and we got I was at Rutgers University in New Jersey at the time, and we got some funding to do a study to help undergraduates cope with the distress of that, COVID year. This was something we had to do very quickly. Everything was moving very quickly at that time. And as part of that study, we developed brief animated videos that taught the DBT skills. And we ran the study where we gave some people access to the skills and some people without access to the skills videos, and we compared things over time. And what we found in that study is that the undergrads who did not get access to the videos reported more distress and difficulty over time, which you might imagine is true of a lot of undergrads in college semester systems. As the semester progresses, people report more stress and more, mental health difficulties. The people that got access to the videos stayed the same. They did not get more distressed over the course of the semester. So it's not like they got much better, but they stayed the same, which we could actually say is a positive outcome here. We ended up taking those videos and just deciding like, okay, let's put them on YouTube and make them publicly available to anybody who wants to see them. And we had no idea sort of what kind of audience it would have. And it ended up that people really loved them. They loved learning from the videos. People who teach DBT skills in groups use, like psychologists and therapists who teach DBT, use the videos when they're teaching the skills. They now have millions of views on YouTube. We've translated them to different languages. So that would be another place to get some initial understanding of what the skills are. It's the channel is called DBTRU. And it's DBT Skills by Experts, I think, is the channel. And it's actually based on those animated videos that gave us the idea of a book that incorporated some illustration and incorporated more down-to-earth ways of learning.
This is probably a question you get a lot, so it's going to be a boring one, but is things like whatever, ChatGPT or Gemini or those things, is that competition for what you're doing because people can go on and try and have those conversations with AI, or is that almost like an add-on to what you're doing?
It's a great question. I actually don't see it as competition in the sense that we have an extreme access problem in the mental health field where so many more people need access to mental health options and services than we have mental health clinicians. So the problem I see with GPT or AI, we actually wrote a piece that was published in Time about this, is that the current models of AI are really focused on keeping and increasing engagement. That's their metrics. Do people stay and chat longer and longer, right? And if you've ever used AI or ChatGPT, you probably have seen, as I have, you ask it a question, it gives you an answer, and then it asks you, do you want this other thing? Right? Like it wants to keep you engaged and going. And the way that people are using AI for mental health issues often leads the AI to respond with validation. Oh, that sounds really hard. Oh, you're doing the best you can. Oh, you don't need to go. If you're feeling bad, you don't need to go out. You could just stay home and take care of yourself, right? That's actually what we're seeing the guidance be from AI. So I think what we need to do is train AI better so that it can be more likely to offer skills and change when people present with the problem. If a person is savvy enough, they can go into ChatGPT and they could say, teach me a DBT skill for X, Y, and Z problem, and ChatGPT will give it. So that's great. But most people aren't savvy enough to, or don't know, to write that. And then they're kind of left with wherever the conversation involves, which might not necessarily be helpful.
Do you think that overall, like the AI is a net positive for the field because more people have access, or is it a net negative because you lose that? I think there's a humanness about, like, I've never seen a therapist, but I imagine that I think a humanness would be important to me. If I probably should see a couple of therapists, but
I'll give you my number. No, yeah. I think it's yet another tension. I think we want to develop tools that will help people and be accessible. And we have to be really careful. And what we've noticed, I mean, this is not, AI, of course, is bringing it all to the forefront right now, but this has always been true. There's always been this tension between technology changes and psychology and psychotherapy access. The problem is researchers, clinicians who do treatment research cannot keep up with the pace of technology. So for example, I, early on in my career, was working on a mobile phone app that could coach people in DBT skills. But this was so early on in the days of apps that we were very limited in kind of like how we could construct that. And of course, now things are exploded and they're so different. But the second I finished that study, it was out of date. There's nothing I could do with what I had developed because nobody was using that kind of technology anymore. And I feel like that happens with any technology, is that it just happens so rapidly that we don't know how to harness it and use it effectively before we're on to the next thing.
That makes sense.
And I will say, and again, this is my opinion. I think there haven't been enough research data on this. I think as a result of the COVID pandemic and perhaps as a result of AI and other things, is that people are spending more and more time alone, not engaging in real life with other people. And I do think that is a detriment to mental health. So as much as possible, I advocate for in-person therapy and meetings, because I think that is better overall for people's mental health.
Tools are one thing, but I was wondering what it looks like when someone actually starts to use them. When it's consistent, you mentioned seeing an identity shift, not just I can cope, but I am capable. What does that shift look like when it first appears?
That thought, I am capable, is such an important one. The technical term in psychology is self-efficacy, belief that you can be effective, that you can do something. And we have found through studies that self-efficacy affects outcomes. That the more you improve in your feelings of self-efficacy, I can do this, the more likely it is that you're going to have improvements in other areas of your life. So that's a big one. Now, have I had moments where I noticed that shift? I'm trying to think. That doesn't stand out to me as like these aha moments. And part of that is because I actually think it's a challenge for a lot of people to accept that they are becoming more skillful. I know that sounds counterintuitive maybe, but I think that change from feeling very ineffective to starting to feel effective can be a challenging change for some people because they're afraid that it won't last, or they're afraid that, oh, if I become more skillful and I start doing things a little bit better, more will be expected of me by others, or people will wonder why I haven't been this way all along. So it's a real what's the expression, double-edged sword there, because I think people have a hard time sometimes with learning that they're more capable. And there has to be this addition of validation and self-validation, people learning to say to themselves and believe, there's a reason why I couldn't do this before, and now I can, and I'm doing so much better as a result. That is part of the process.
Shireen, I want to go one layer deeper into trauma, where coping can quietly become a cage. How do you help someone distinguish between healthy coping and subtle avoidance without shaming or pushing them too fast?
Really great question. In the area of trauma and post-traumatic stress disorder, it's commonly believed that, or known, I should say, that not everybody who experiences a trauma or a traumatic event develops PTSD, post-traumatic stress disorder. Only a subset of people go on to develop post-traumatic stress disorder. And the question has always been, well, why? So many people experience horrific traumatic events, and some people recover, not that they ever forget what happened, but that they recover from the traumatic event, and other people have a hard time recovering and stay stuck. And the idea about what differentiates those two folks is that there's in the subset of people who go on to develop PTSD, they initially learn to cope by trying to avoid thoughts about what happened, memories of what happened, but also avoiding situations, people, experiences, all that remind them of the traumatic event. And so when you are trying to help somebody who has post-traumatic stress disorder or various symptoms of post-traumatic stress disorder, you have to work on targeting their avoidance. And that means targeting their avoidance of thoughts and memories, which often looks like, in the context of therapy, actually having the person describe what happened to them over and over again sometimes, as well as targeting the avoidance that they experience in their lives. Like, how do we get you out of the house more? How do we get you to do the things that cause you fear in a safe way so that you can learn that not everything is dangerous? How do you do that in a sensitive way is, I think, the same principle of DBT that we've been circling around, which is this dialectical tension between acceptance and change. That we accept that this horrible thing happened to you. We accept that the reactions you're having are completely normal and make sense given what happened to you. And if you want to not be controlled by intrusive thoughts anymore, if you want to not have nightmares several times a night, if you want to not live your life in fear and avoidance, the only way out is through. And as a therapist, I am going to be doing this with you. That's what I would argue is how you counteract some of those thoughts and feelings about avoidance.
DBT talks about a life worth living. Outside of clinical language, what does that phrase actually mean to you?
Oh, that's a really good question. Because I use it all the time. And so now I'm like, well, how do I explain it even further? I would say a life worth living is one that gives you a sense of purpose, that it has joy and moments of joy in it, but is not always joyful. I think that's something that trips some people up because they think if they're not experiencing joy or happiness all the time, there's something wrong. When in fact, it's not possible, of course, to experience joy and happiness all the time, but also joy and happiness would cease to have its powerful effects if we experienced it a lot. Like, the value of joy and happiness is that when it comes, it feels good, right? So for me, it's a life with purpose. It feels like a life of working towards or striving to do something, whether it's and living in accordance with values. So for me, it's doing what I can in very small ways to improve the lives of others. That gives me a sense of purpose and mission, and gets me out of bed in the morning because I want to do that. And it's not without struggle, and it's not without pain and complications, but I am aware that I'm living in accordance to values that I hold very deep. So I think a life worth living is one in which we are living in accordance with values that we have, and that we are incorporating joy, connection, and self-efficacy, I would say, and pets, having pets.
Are there any mistakes you made early in your clinical career that shaped the kind of therapist and teacher you became?
I have made so many mistakes. I think that's part of the learning process. It's becoming a therapist is really hard. It's really humbling, especially early on when you're first learning. Until you have more experience, it is hard to know certain things like how to validate somebody's experience when their experience is different than yours, for example. But something that I think about a lot, I actually wrote a journal article about this a long time ago, a mistake that I made in a really challenging therapy context was that I had failed to assess for a particular problem that the person had that they did not tell me about. And it wasn't until they ended treatment with me on their very last session with me that they disclosed the problem that they had that they had not told me about for over a year. So I don't know if that was like so much a mistake on my part, in that I don't think I did something wrong, but what it highlighted to me is how important it is to recognize that we don't always know everything that's going on. It's the humility of that. And it also highlighted to me the importance of always continuing to assess, like, what am I missing? We've been working on this for, X number of months and it's not changing, or you don't seem very willing to do this. What am I missing? In the hopes that I can get somebody to open up about something that they feel so deeply ashamed about that they don't even tell their therapist about it. That's a really heartbreaking memory for me, because I feel like if I had known, maybe I could have been more helpful. And what could I have done to make this person feel like she could share that with me? And to just think about that as I work with anybody else now.
Looking forward, what do you hope DBT becomes over the next decade? More accessible, more humane, more integrated? And what has to change for that to happen?
Over the next 10 years, I hope that it becomes even more accessible to people who need it. And I hope that we continue to do research to identify who would most benefit from DBT, how much DBT is needed. We still don't really know what's a good length of DBT in terms of getting to the outcomes that we'd be looking for. So who would most benefit? How much DBT is necessary? Who just needs some access to the skills, like the skills videos or a skills book, and will learn from that and have lives be changed by that, versus who needs one-on-one time with a therapist? I think that's a really important question, because as I mentioned, we have a real access problem. And if we don't have enough therapists to treat all the people who need help, how do we figure out who actually would benefit from the one-on-one with a therapist versus who can actually improve and develop their knowledge of the skills on their own or in a less intensive way? And I hope that, I'm sure this is true of every field, but I just happen to know the field that I'm in the best, which is, psychology and psychotherapy, is there's always some new fad treatment that comes out, and everybody gets really excited about this new fad treatment and sort of jumps on the bandwagon of that. And I've seen this now that I'm older. I've seen this happen so many times, that there's a new fad and people jump on the bandwagon of that, and it might move the needle a little bit, but actually not very much. And what we always see is kind of a return to cognitive behavioral therapy and behavior therapy as being ultimately the most efficacious treatment for a number of problems and disorders. And so what I hope is that we can kind of avoid, I think this is an impossible hope, but avoid the jumping on the bandwagon with all sorts of fads, and instead devote our resource and time to improving access to evidence-based treatment with skilled providers, because I think that will be most likely to lead to sustained change.
Under every clinical framework is a question it cannot fully answer. Sitting with so much suffering inevitably raises spiritual questions. Where has your faith been challenged, reshaped, or clarified by this work? And how has that influenced how you love others? Personally, I was metamorphosized by my ALS diagnosis. I have been driven further into my Christian faith, whose currency is love.
Yeah, so first I'll answer this question actually from the perspective of Marsha Linehan, who developed DBT, who identified strongly with her own Catholic faith and upbringing, and incorporated into as she was developing the treatment, as she was building her own life worth living, she also was exposed to principles of Zen and Buddhism and incorporated that into the treatment, not Buddhism, but mindfulness principles of Zen. And something that Marsha talks about actually is in her memoir. You would read this in the article in the New York Times about her, is that how profound her spiritual beliefs, how profound a role that played in her own getting out of hell experience, and also in her steadfast work on developing this treatment. As a counter to that, I will say that I've actually never considered myself an especially spiritual person or a person of faith. And yet I feel the same passion about improving the lives of others and working through love, as you say. So maybe others would say that that's faith and that's spirituality, and that's probably a whole other discussion. But I think that I have found meaning in the work that I do without having that same strong spiritual foundation.
Before we close, brag about your family for a moment. Tell us about what you most admire about the people you go home to, and one thing you hope they always know about you, no matter how hard the day has been.
All right. Well, first I'll brag about my husband and 2 children and 3 cats. They're all incredibly fun, loving, smart people who also sometimes drive me crazy, but for the most part are fun, loving people. And I'm really proud. It's such an amazing experience to watch your children. I'm sure, Tim, you had this experience, and Troy, I don't know if you have kids, but who watch your kids grow from toddlers and elementary school to actually becoming, cross that threshold into becoming real people with their own interests and skills. And that's been kind of amazing and friendships. That's been amazing to watch. What do I hope they always remember about me? I hope they always remember about me, first of all, of course, how much I love them, but also how much I love my work and how important I think it is to try to improve society, your neighborhood, your small town, the world, in whatever small or big ways you can. That I think that's one of our missions, is to give back more than we take.
Now on to our final word segment, where we ask our guests a few rapid fire questions. What was the happiest moment in your life?
I feel like as a mother and a wife, I'm supposed to say having my babies or getting married. And those were very happy moments. But the thing that first came to my mind was running the New York City Marathon in 2008, which stands out as one of the happiest days of my life.
What is the biggest adversity you've faced?
What would seem like the obvious answer would be to say my cancer diagnosis, but in many ways I felt like I was privileged enough to have amazing doctors and resources and confidence in my treatment, that when you ask that question, that it doesn't feel right to say that for me. I would actually say one of the bigger adversities that I had to overcome was when I had my first child. my older son, he cried constantly and did not sleep for more than 15 minutes at a time for what feels like months. And I felt so out of control and incompetent and tired and exhausted that I think was probably in many ways that 6 month period was tougher than my cancer period. Didn't have as much support during that time.
Very real response.
What are you most excited about?
I am excited to watch my kids continue to grow, but I'm also excited about thinking what are the next steps of I'm somebody who doesn't like to stay still for very long. So even though we just finished this book and I'm like, oh, that was so exhausting. I don't know if I could write another book. I also know that within a couple of months, I'll start to get an itch to work on some other new project. And so I think what I'm excited about is also trying to figure out, like, we're trying to figure out how do we get these skills to people who need them. But I think the other thing I want to figure out is how do I get therapists and mental health clinicians to be more skilled themselves, to learn how to do more effective treatment. And so thinking about ways in which I can, whether it's a book or other kinds of resources to help improve clinicians' capabilities. That's what I'm excited about next.
What advice would you give your younger self?
This sounds corny, but I would say my younger self, I would say life definitely gets better. And what I mean by that, or what I would tell my younger self, is that the younger self who would be so upset when a date didn't call me for a second date, or I didn't do as well on tasks that I wanted to, that those things are kind of more small stuff that won't be as important and influential in your life as you get older and you really focus on what's most meaningful.
Do you have any book recommendations for us or for the listeners?
So I would definitely recommend for anyone interested our book, Real Skills for Real Life, which teaches a number of the DBT skills. But if you were interested in some of the questions and discussion points that Tim was talking about, I think Marsha Linehan's memoir would be really interesting for people, and it's called Building a Life Worth Living.
The name of our podcast is Nothing Left Unsaid. Do you have anything you want to say?
I really want to say that this was probably the hardest interview that I've had, but that I also really enjoyed the challenge. And I just feel appreciative that you had me on. And I hope I did a decent job.
Yeah, it was great. Hey, before we let you go, the last question I always ask is, now that you got to know us and the podcast a little bit, who are a couple of people that you know personally that you'd recommend we try to have on as future guests?
Ooh. Unfortunately, I mean, I would say Marsha Linehan, but actually she's retired and not able to participate in something like this. But I am thinking along the lines of suffering and how people react to suffering. And what comes to mind are actually some people who write on Buddhist principles. So like Sharon Salzberg or Joseph Epstein, who have written a lot of books on Buddhist principles and how they relate to suffering, I think would be a really fascinating conversation.
Shireen, thank you for the lives you serve and the clarity you bring to human pain. You reminded us that growth is possible, that skills can become anchors, and that love, especially in family, is often where the real work is lived out. We're grateful for your time, your honesty, and your heart. May God bless you and your family.
Thank you so much. I really feel so privileged to have been here with you.
Yeah, thank you. All right, we'll talk soon.